Welcome, deep divers. Ever thought that, well, sometimes high blood pressure isn't just high blood pressure?
Hmm.
What if there's a specific cause, often missed, that leads to really serious health risks?
It happens more than you might think. A hidden cause behind a common problem.
Exactly. And today, we're doing a deep dive into that very thing. We're
Mm.
unpacking the latest guidelines on primary aldosteronism, PA for short.
Right.
We want to help you understand what it is, why finding it matters so much, and how it's actually being identified and treated now.
Think of it as getting you up to speed on a really crucial but maybe under the radar health topic.
So let's start right there. What exactly is primary aldosteronism?
Okay, so simply put, it's a disorder involving your adrenal glands, those little glands on top of your kidneys.
Right.
And what happens is either one or both of them start producing too much of a hormone called aldosterone.
Okay, too much aldosterone. But what makes it primary aldosteronism? What's the key detail?
Ah. The crucial part is that this overproduction is at least partially autonomous.
Autonomous? Meaning,
Meaning it's working on its own. It's not listening to the body's usual control system, the renin-angiotensin system. In fact, that system gets suppressed, turned down.
oh, interesting. So it's like a rogue factory churning out aldosterone regardless of demand.
That's a great way to put it, yeah. And this rogue aldosterone forces your kidneys to hang on to extra sodium,
Okay.
which then makes your body retain water, leading to volume expansion, and that drives up blood pressure.
And sometimes low potassium too, right? Hypokalemia.
Yes, exactly. In more severe forms, you can definitely see low potassium levels as well.
And this isn't just about slightly higher blood pressure numbers of it. The so what factor here seems pretty significant.
Oh, absolutely. The risks for people with PA are considerably higher than for those with, say, standard essential hypertension. We're talking increased risk of heart attack, stroke, kidney problems, even atrial fibrillation.
Wow. So despite being potentially common and definitely serious, it sounds like it often flies under the radar.
That's the core problem these guidelines are trying to address. It's largely underdiagnosed and undertreated, a hidden threat, really.
So the goal of these new guidelines is
Yeah.
what? To shine a spotlight on it.
Essentially, yes. To boost the identification of people with PA, and then through specific treatments, either medical or surgical, to really improve their blood pressure control and cut down on those associated cardiovascular risks.
Get to the root cause, not just manage the symptom.
Precisely.
Okay, that sets the stage perfectly. So if identifying it is so important, let's talk screening. Why is screening so crucial now? Are they saying screen everyone with hypertension?
Well, that's one of the big shifts here. The guidelines lean heavily towards being proactive. Recommendation 3 basically suggests screening individuals with hypertension for PA.
Okay, and how do they suggest doing that? What's the test?
The go-to is measuring both the aldosterone concentration in the blood serum or plasma and the plasma renin level. You can measure renin's concentration or its activity.
And are there specific conditions for the test, like time of day, posture?
Yes, good question. It should be done in the morning with the person seated. And this is important. They shouldn't be restricting sodium in their diet for a few days beforehand.
Why no sodium restriction?
Because restricting sodium can actually stimulate the renin-angiotensin system and might mask the suppressed renin that we're looking for in PA.
Ah, okay. And you mentioned potassium earlier. Is that part of the screening?
Potassium itself isn't used to screen for PA, but it absolutely needs to be measured alongside renin and aldosterone.
Why is that?
Because if someone's potassium is low hypokalemic, it can falsely lower their aldosterone level. So you need that potassium value to interpret the aldosterone result accurately.
Got it. Another potential pitfall. What about medications? Do common blood pressure drugs interfere?
Oh, definitely. That's a huge factor. Many blood pressure meds can affect renin or aldosterone levels. The guidelines provide strategies for this, sometimes minimal withdrawal, sometimes just interpreting the results in light of the medication, sometimes pausing meds for a bit if it's safe.
Okay, so it requires some careful planning. Now, once you have the results, what makes a screen positive? What are you looking for?
There are sort of 3 key things that signal PA. Rule number 1, the absolute hallmark. Renin is suppressed, very low.
How low is low?
Typically, we're talking plasma renin activity, PRA, less than or equal to 1 nanogram per milliliter per hour. Or if using direct renin concentration, DRC, less than or equal to about 8.2 milli units per liter. Basically, the system is shut down.
Okay, suppressed renin. What's rule number 2?
Aldosterone is inappropriately high for that suppressed renin level. Generally, using standard immunoassays, that's an aldosterone level of 10 nanograms per deciliter or higher.
And if using the more sensitive LC-MSMS method?
Then the cutoff is a bit lower, around 7.5 nanograms per deciliter or more.
Okay, low renin, high aldosterone. And the third piece, the ratio.
Exactly. The aldosterone to renin ratio, or ARR. With immunoassay, a ratio greater than 20 is usually considered positive. Using the metric units in DRC, it's often over 70.
And with LC-MSMS?
The ratios tend to be about 25% lower, but again, it's that pattern, the high ratio driven by low renin and relatively high aldosterone.
But you mentioned earlier, these aren't absolute hard lines.
No, exactly. These are guideline cut points. Local labs might have slightly different reference ranges, and you always have to consider the individual patient, their pretest likelihood of having PA, and, critically, any medications they're on. No single number tells the whole story.
Right. Context is key.
Yeah.
So given that complexity and the chance of false results, when would you need a retest?
Several situations. If the first screen is negative, but you suspect a false negative, maybe because of low potassium at the time, or because they were on certain interfering meds like MRAs or diuretics.
You'd fix the potassium or pause the meds and test again?
Correct. Pause MRAs or ENaC inhibitors or diuretics for about 4 weeks if safe. ACE inhibitors or ARBs for maybe 2 weeks, then repeat the screen.
What if the screen is negative, but you still have a strong clinical suspicion, like someone with a really resistant hypertension?
Yes, if the pretest probability is moderate to high think-resistant hypertension, or that unexplained low potassium, or maybe if renin is suppressed but aldosterone is just borderline, repeating the test on another day is a good idea.
And the flip side, what about potential false positives?
Right. If the screen looks positive, but the person is taking a drug known to lower renin, like a beta blocker or certain alpha agonists, that could create a false positive.
So you try stopping those meds.
If it's safe, yes. Withdraw them for about 2 weeks and retest. Though it's worth noting, if the aldosterone level is really high, it's probably true PA even with those drugs on board.
Any other tricky situations?
Chronic kidney disease, CKD, is one. Renin tends to decrease as kidney function worsens, and aldosterone can sometimes be elevated, potentially mimicking PA, so careful interpretation is needed there.
Okay. And what if someone screens negative now, but things change down the road? When might you rescreen them later?
Good point. You'd think about rescreening if they develop hypertension that suddenly becomes worse or resistant to treatment, or if they develop low potassium, either spontaneously or triggered by diuretics, or maybe new onset atrial fibrillation without a clear cause. Keep PA in mind if new red flags pop up.
Okay, so screening is step 1. If that's positive, you need to confirm it. This brings us to aldosterone suppression testing, recommendation 4. Is this always the next step?
Not always, no. It's suggested mainly when the screening results are kind of in an intermediate zone, not slam dunk positive, and the person is actually considering surgery as a treatment.
Why only them?
Because the suppression test helps confirm that the aldosterone production is truly autonomous, truly independent of the body's controls, but it's a more involved test.
So when would you definitely skip this confirmation step?
You'd skip it if the initial tests already show really obvious PA, like rock bottom renin and sky high aldosterone. In those cases, the suppression test might even give a false negative result.
Okay, what else?
Also, if the patient isn't willing or able to go further down the diagnostic path, like towards adrenal venous sampling or surgery, then there's often no point in doing the suppression test. You can just treat them medically based on the strong screening results.
Makes sense. Any other scenarios where you'd skip it?
Yes, in cases of known familial hyperaldosteronism, genetic testing is the way to go. And also, if the overall picture suggests the likelihood of finding a one-sided source, lateralizing PA, is very low, say someone with normal potassium and only moderately elevated aldosterone, you might bypass suppression testing.
Right. And you mentioned familial hyperaldosteronism, genetic screening is recommended there.
Yes, for first-degree relatives, and particularly if someone develops PA very young, like under age 20.
Okay, so once PA is confirmed, we get to treatment. Recommendation 5. Is it always medication or is surgery an option?
It really depends. The key factor is whether the excess aldosterone is coming from just one adrenal gland, that's called lateralizing PA, versus both glands, which is bilateral PA. And, of course, whether the patient is a suitable candidate for surgery and wants it.
So if it is coming from just one side,
Then total unilateral adrenalectomy, removing that one problematic adrenal gland, usually laparoscopically is the preferred option, potentially offering a cure.
and if it's bilateral or the source isn't clear or surgery isn't feasible,
Then it's lifelong medical therapy. The mainstay is using a class of drugs called mineralocorticoid receptor antagonists, or MRAs.
are there times when you might just go straight to medical therapy without figuring out the one side versus two side question?
Yes, definitely. People with milder forms of PA often have bilateral disease anyway, so they might proceed directly to MRA therapy, potentially skipping the more invasive tests like AVS.
AVS being eating?
Adrenal venous sampling, we'll get to that. Also, patients with lots of other health problems who aren't great candidates for surgery would typically go straight to medical management too. It's patient-centered.
Okay, so let's talk about figuring out that one side versus two side issue, lateralization for those considering surgery. Recommendation 6 mentions imaging and this AVS. Why is knowing the source so critical?
It's absolutely vital if surgery is on the table. You have to be sure you're removing the correct adrenal gland, the one causing the problem.
So how do you pinpoint it? CT scans.
CT scanning is part of it, yes. It shows the anatomy, looks for nodules or adenomas, but the guidelines stress that the gold standard combines CT with adrenal venous sampling, AVS.
Why isn't CT alone enough? It seems like it should show you the problem lump.
That's a really important point. A lump seen on CT isn't always the source of the excess aldosterone. It could be a non-functioning nodule, quite common actually. And sometimes the overproducing cells are diffusely spread, not forming a distinct lump.
Ah, so the CT shows structure, but not necessarily function.
Exactly. AVS assesses function. It involves threading catheters into the veins, draining each adrenal gland, and measuring aldosterone levels directly from each side. That tells you definitively if one side is overproducing compared to the other.
That sounds quite specialized.
It is. It requires experienced interventional radiologists, but it's considered essential for reliable lateralization before surgery in most cases.
Are there any exceptions where you might skip AVS?
The guidelines suggest one potential exception. A younger patient, say under 35, who has really marked PA, low potassium, and a clear single adrenal adenoma larger than a centimeter on CT. In that specific scenario, the likelihood of that adenoma being the culprit is very high, and some centers might proceed to surgery without AVS.
Okay, that makes sense for a very clear picture. Now, shifting back to medical management, Recommendation 7 talks about optimizing MRA therapy. What's the guidance if someone's blood pressure isn't controlled and their renin is still suppressed, even on treatment?
The suggestion there is to actually increase the dose of the MRA or other PA-specific therapy with the goal of raising the renin level.
Raising renin. Isn't low renin the problem?
Low renin is the hallmark of untreated PA. When you effectively block the excess aldosterone's effects with an MRA, the body should sense this, and the renin level should start to come up from its suppressed state. Seeing renin rise indicates the MRA is doing its job at the receptor level.
So the goal isn't a specific renin number, but just seeing it increase from baseline.
Exactly. It's a physiological marker that you're achieving better blockade of the aldosterone effect.
Interesting. Okay, another test mentioned is the dexamethasone suppression test, Recommendation 8. This is for PA patients who also have an adrenal adenoma found on imaging. Why do this test?
This is to check for co-secretion of cortisol. Sometimes an adrenal adenoma causing PA might also be autonomously producing cortisol, leading to Cushing's syndrome, or what's often called autonomous cortisol secretion, ACS.
How does the test work?
It's usually a simple overnight test. The patient takes 1 milligram of dexamethasone late at night, and their cortisol level is checked early the next morning. If the cortisol level isn't suppressed, typically if it's still above 1.8 micrograms per deciliter, it suggests ACS.
And why is knowing that important?
It's crucial, especially if adrenal surgery is planned. Removing an adrenal gland that's been overproducing cortisol can lead to temporary or sometimes permanent adrenal insufficiency afterwards because the other adrenal gland might have become suppressed. Knowing about ACS beforehand allows the team to anticipate and manage this risk, often with steroid coverage around the time of surgery.
Right, prevents trading one problem for another. Now, choosing the specific MRA for medical therapy, Recommendation 9, is there a preferred one?
The guidelines suggest spironolactone as a primary option, mainly because it's effective, low cost, and widely available.
Are there downsides to spironolactone?
Yes, it can have side effects related to blocking androgen and progesterone receptors, things like gynecomastia in men or menstrual irregularities in women. For patients who experience those, other MRAs like Eplerenone or finerenone might be preferred as they are more selective for the mineralocorticoid receptor.
But effectiveness-wise, they're similar if dosed right.
They're expected to have similar efficacy when titrated appropriately. Whichever MRA is used, the key is careful monitoring, checking potassium, kidney function, renin levels, and blood pressure to guide the dose adjustments.
Okay. And the final recommendation we'll cover, number 10, compares MRAs to another class, the ENAC inhibitors like amiloride. Where do they stand?
The guidelines generally favor MRAs for PA-specific therapy over ENAC inhibitors. MRAs target the actual receptor being overstimulated by aldosterone.
But are there times ENAC inhibitors are used?
Yes, important exceptions exist. If MRAs are contraindicated, for example, due to significant hyperkalemia risk, severe kidney impairment, or during pregnancy, then an ENAC inhibitor like amiloride might be used. Or sometimes it's added on if MRA therapy alone isn't sufficient.
Got it. Wow, we have really covered a lot of ground today. A true deep dive into primary aldosteronism.
We certainly have. From definition and risks to the nuts and bolts of screening, confirmation, and treatment pathways.
And it really highlights how a condition that might just look like high blood pressure on the surface can have this very specific identifiable cause.
Absolutely. And knowing that cause allows for targeted treatment that can dramatically change someone's long-term health outlook, moving beyond just symptom management. It's quite remarkable, really.
It really is. So that brings us to our final provocative thought for you, our listeners, to consider. Given how vital early and accurate diagnosis is for PA, how can we better integrate this knowledge into routine health screenings? What innovative approaches could help bridge the gap between these expert guidelines and everyday clinical practice, ensuring more people who have PA get identified before serious complications set in?
A critical question for improving cardiovascular health on a larger scale. How do we make this specialized knowledge more universally applied?
Something to definitely think about. Thanks for joining us on The Deep Dive.